Good morning, good afternoon, and good evening, everyone. I'm Benedict Walter from the Secretariat of the Network for Improving Quality of Care for Maternal, Newborn, and Child Health. Welcome to what is the 6th webinars in a series on transforming care for small and sick newborns, which is organized by UNICEF and the World Health Organization in collaboration with the Network for Improving Quality of Care for MNCH. We have 3 speakers today, and the presentation will last about half an hour, followed by half an hour of question and answers. So while you all muted, please type your question in the chat box on the bottom right corner of your screen, and we will read them out in the second half of these webinars for the panelists to answer. We will also record this session and have it on YouTube live, and we will send you later today a link with this recording as well as the 3 presentations that you will hear today. I would like now to introduce you to the facilitator for this session, Dr. Gagan Gupta, who is a health specialist at UNICEF, and will run you through today's agenda. Gagan.
Thanks, Benedict. Good morning, good afternoon, and good evening, colleagues. Greetings to all of you from UNICEF headquarters in New York. I'm Gagan, your moderator for today's session. It has been exactly 71 days, 11 webinars, 22 speakers, and 1,300 plus champions for mothers and newborn tuning in from across the world since we first started on 6th of May with this series on transforming care for small and sick newborn. And all along the way, we have highlighted the glaring need for an urgent action. With already more than 60 countries currently off track to meet the SDG target for neonatal mortality, and 26 million neonatal deaths projected till 2030. And on top of it, the macro data from countries showing COVID-19 is indeed impacting coverage and utilization. The lives of millions of newborn truly hang in balance today. With this background, as we reach the last and the final webinar of the series, it's indeed time for immediate action. Collaboration between 26 organizations and 94 authors across 6 continents is what it took to bring all the pieces of small and sick newborn together in this must-read global report. Today, we will be focusing on the last chapter of the report, that is, immediate action is needed. And to take us through this, we have with us Judith Ropp McCord, Vice President, Technical Leadership and Support at PCI, Dr. Victoria Chiu, Assistant Scientist in the Department of International Health at Johns Hopkins, and Dr. Ornella Linsetto, Senior Medical Officer for Newborn Health at WHO. She is also a lead editor of this report and a true champion for newborn health. So let's start the ball rolling. Over to you, Judith.
Good morning and good afternoon to everyone. Gagan, thank you so much for that very inspiring introduction to today's webinar. It's a pleasure to be here with everyone, and I really want to thank all of you for your continued participation. As Gagan has said, this is a presentation of the 6th and final chapter of Survive and Thrive. And our vision when designing the document was a call to action based on data and evidence about what needs to happen to transform care for every small and sick newborn so that they survive and thrive into the future. The presentations over the last several weeks have been very inspiring and incredibly informative, and I want to thank all of you for facilitating its dissemination as well as the call to action. This has been a truly collaborative effort, and I'm excited to share with you highlights from Chapter 6. We designed 3 key messages for Chapter 6, and essentially we know what works to save the lives of women and newborns and to prevent stillbirths. You'll learn from Dr. Chu's presentation that if we can expand coverage of key interventions before, during, and after pregnancy, 2.9 million women, newborns, and stillbirths could be saved by 2030 in 81 countries. In addition, by investing in quality newborn care, 1.7 million newborn lives could be saved each year, and nearly half of that impact would result from providing special and intensive hospital care. And finally, To reach our SDGs and the ENAP targets to end preventable newborn deaths by 2030, care for small and sick newborns must be transformed through collective stakeholder action, health systems investments, information and innovation, and implementation of proven interventions. I'd like to now hand over to Victoria Chu from Johns Hopkins University, and Victoria will take us through the lives saved analysis that she and her team conducted building from the Lancet Every Newborn series. Victoria.
Thank you, Judith. So my goal for today is to explore the analysis that was done to support Chapter 6 and to understand some of the assumptions and some of the sort of underlying questions that we were trying to answer in trying to determine sort of what immediate action is needed and what are the possible consequences or benefits that we could gain. So I know that folks may have heard about the LiveSave tool. It is a evidence-based platform that's been developed or has been expanded since introduction with the Lancet Child Survival Series in 2003. And so since then, this mathematical modeling tool has been used really widely for evaluation, strategic planning. And the goal or the sort of main approach is based upon estimating what is the current coverage of key interventions in low resource settings, predominantly low and middle income countries, and what are the benefits or what are the anticipated gains that we would expect to achieve if we were to scale up or expand coverage of those key interventions in these contexts. So the analysis I'm going to present, as Judith mentioned, builds upon the work that was done for the Lancet Newborn series. And the scope of the analysis focused on 81 high-burden countries. And so for those countries that represent the majority or greatest proportion of maternal neonatal deaths, we compared for these 81 countries 4 scenarios. And so the comparison to baseline is a counterfactual. It just says, you know, if nothing was to have changed, what would be the gains or benefits if we were to achieve 4 different scenarios or 4 different scenarios were to play out. So the starting, we had set targets from the baseline to reach targets in either 2025 or 2030. And the software allows us to estimate from this, with this integrated approach, what would be the impact of specific interventions. And so next slide. What we're able to break out is for the individual population subgroups, the benefit for maternal lives and almost a 40% reduction in the number of deaths averted compared to a whopping, a large majority, a proportion of the neonatal deaths, which we would prevent, the 1.7 million, which was highlighted as one of the key messages, as well as the number of stillbirths that could be prevented. So in these, in this analysis of the 81 countries, what we can also look at is the contribution of individual interventions to that large envelope or that sort of sum total of impact that we talked about. So the idea is that for current coverage of interventions, by estimating where is the current, where we are currently, then setting the sort of roadmap or the trajectory for the scenarios to say by 2030, if I was to move the coverage needle and advance so that more women, more newborns, and children were getting the care, high quality care that they needed at those critical time points, what would be the benefit? We were able to look at specific interventions. And so the specific disaggregated analysis to look by intervention says of that large impact, the 1.7 total newborn lives we could save, the 747,000 of those newborn lives would be saved by these efforts around dedicated special and intensive hospital care for the smallest and the sickest newborns. Next slide. So as I mentioned, the analysis focused on estimating for the sort of majority or the global impact. Next slide. And then drill down to say, okay, if we were to close the quality of care gap. So within our current framework for the LiveSave tool, coverage of key interventions would be broadly defined as the percentage of women or newborns or population of interest in need of an intervention who are receiving it as the numerator over the denominator of all those in need, the simple sort of quantification of coverage, is driven by two contributing factors. One, which is utilization, like the percentage of health facility births which are recorded, or the percentage of women who are seeking antenatal care, in combination with quality of care. And we all know from other speakers in the survey and on this series, as well as those so actively engaged in improving quality of care, that one of the critical factors to address is the quality gap, so that at those critical time points, the resources are available in terms of trained staff resources, and adequate high quality care is being delivered at those critical time points. So when we look at closing the quality gap, and we say 28% of those newborn deaths could be addressed by targeting or closing those quality gaps, by ensuring that high quality care is available to those newborns at the time of need. Next slide. The other advantage of one of the advantages of the Lives Saved tool is the ability to be able to look at cause-specific mortality. So within each one of the main causes for neonatal death, the first slide focuses and is presenting the contribution of individual interventions to reduce deaths during the neonatal period due to intrapartum related birth complications. So what we see is that some of the interventions are those which are delivered during the antenatal period for women, and some of those are immediately postnatal. So neonatal resuscitation, proper labor and delivery management would be the leading drivers to reduce neonatal deaths due to intrapartum related birth complications. Next slide. And when we're looking at infection as a cause, some of these critical intervention or critical initiatives that people are undertaking to improve quality of care in terms of having adequate cord care, having antibiotics if needed to treat infections, the most important interventions here are shown that would be instrumental in reducing the number of neonatal deaths due to infection. Next slide. For prematurity or for preterm related neonatal deaths, the largest contributor would be contributor, meaning these are the interventions that when we estimated scale up, these are the ones that will give you the sort of greatest gains or benefits, are related to case management of premature babies through either kangaroo mother care, intensive care, and it demonstrates what is the value of scaling up these high impact interventions. Next slide. So as we've mentioned, this analysis, which looked at the global burden of neonatal mortality, said if we could scale up these key interventions and listed separately or sort of examined individually, if we could scale up this package of interventions, we could achieve an 86% reduction in deaths due to prematurity, a 76% reduction due to intrapartum related birth complications, and a 74% due to infection. And so this helps us to understand sort of, this is the reason this analysis was housed in chapter 6 is immediate action is needed. Now we've sort of said, these are the interventions that are available to us and they have demonstrated effectiveness. Now, what could we accomplish? Next slide. Related to the impact analysis, so to look at sort of what are the gains that could be achieved, was a costing sub-study. So the costing sub-study just wanted to examine if we were to really set those goals and if we really wanted to reach the top of that mountain, what resources would we need, and what would be the costs associated? And so the costing framework is an ingredients-based approach, which allows us to say, these are the individual components in terms of drugs and supplies and personnel or the workforce. And for that package, for scaling up that package of inpatient care for smaller sick newborns, would be a total of $959.3 million. So we are able to say, this is how much benefit we would be able to achieve, and this is some of the costs which are sort of not negligible. The next part of this presentation, I'm going to turn back over to Judith, who's going to talk about sort of the path to 2030 and what does that require? Because now that we sort of have this roadmap that's been set out ahead of us, she's going to present sort of concrete steps and immediate action which is needed for each one of the strategic objectives.
Thank you so much, Victoria. Hugely informative presentation and an incredibly important presentation exercise as we look to the path to 2030. This has a list. Next slide, please. Thank you, Gagan. Right here, you see a list of some of the requirements to move us successfully to 2030 and the achievement of SDG 3.2. So essentially, we need to revitalize advocacy efforts to create actionable priority policies. And a country's laws and regulations should assure that health security for women and their newborns, including those belonging to the most vulnerable groups, such as migrants and refugees. And they need to be aligned with international and domestic human rights standards, most notably the Convention on the Rights of the Child. A large proportion of newborn deaths and disability, as you learned from Victoria's presentation, would be prevented by refining existing systems and ensuring that all newborns and their families are able to access the care they need, and also by ensuring rights-based and family-centered approaches with a focus on quality, equity, and dignity. At the same time, governments and other actors need to work collaboratively to scale up a comprehensive set of interventions along the continuum of care to ensure that health systems provide full access to quality, essential, and special newborn care, including intensive care. And also, finally, we need to ensure that we're moving in the right direction and making the right decisions about care with accurate, reliable data for decision-making and accountability. As we look at the slide that's here in the strategic objectives, to create our framework for action, we used the ENAP objectives and adapted them to focus specifically on small and sick newborns. So when we go through the slides for each one of the objectives, you'll note that we used the Born Too Soon framework of invest, implement, inform, and innovate to frame action across the 5 strategic objectives. And we've listed illustrative examples for each, and I'll just highlight a few of those by objective. It's important to note, however, that countries must create context-specific plans using available data and information. Next slide. For strategic objective 1, we expanded the language here to emphasize the provision of care for small and sick newborns. And while many lives can be saved with quality maternal and newborn care, country stakeholders need to plan for and invest in care around the time of birth, as well as inpatient care for small and sick newborns. We can invest in assessing available maternal and newborn care in humanitarian settings. We can ensure that international newborn care standards and guidelines are adapted and available in facilities at the country level. And we can improve data collection efforts to increase our understanding of where, when, and why newborns are dying. Next slide. Regarding strategic objective 2, this goes also to Victoria's presentation about closing the quality gap. We know that most births now occur in healthcare facilities, and this offers a unique opportunity over the next decade to reach women and newborns with improved care. However, health system improvements need to more intentionally focus on improving the quality of this care, including creating a hospital environment that actively welcomes and engages parents in the care of their newborn. It's important that governments ensure each level of care has the necessary staff, equipment, commodities, and diagnostics to deliver quality care, and that longer-term outcomes for newborns with disabilities are being tracked to better assess the impact of inpatient care that they've received, and also services for early childhood development. And next slide. To close the healthcare equity gap and accelerate progress to the SDG target, we need to develop and enact UHC policies, eliminate social and financial barriers to care with particular emphasis on female newborns, use data to design context-specific action plans, and design financial schemes to protect families from catastrophic out-of-pocket expenses. Next slide. Harnessing the power of parents, families, and communities was a theme that we built into the document from the first chapter all the way. This is an extraordinarily important aspect of this important work. And we used the WHO framework for integrated people-centered health services to promote empowering and engaging people and communities in care. And in this case, the small and sick newborn, and often the mother, the father, or other caregivers are at the center of that people-centered continuum or framework. It's critical that we promote family-centered care principles for the care of small, sick newborns, that we're connecting community health workers with local organizations to expand community outreach for post-discharge follow-up of vulnerable newborns, that we educate and engage men to understand the needs, the risks, and danger signs of pregnancy, childbirth, and the postnatal period, and that we're engaging parents in the design and use of new products and approaches to care. Regarding strategic objective 5, we know that right now too little information is currently available on small and sick newborns, especially in low-income countries and in humanitarian settings. We need accurate, reliable data to facilitate planning and decision-making and to build accountability with stakeholders. We need to routinize the process of collecting and using population-based and facility-level data to advance newborn care in low-resource settings, and to better measure the quality of that care, as well as the outcomes and impact of interventions and programs. And this will require that health systems update how they identify, track, and measure small and sick newborns. Next slide, please. So we also spent quite a bit of time developing research priorities to guide change, knowing that there are still a lot of unanswered questions with respect to care, how that care is delivered, as well as in the innovation use of new products and services for the care of newborns, small and sick newborns. So we use the description, discovery, development, and delivery framework to highlight examples of key research priorities that can be used to inform the design and delivery of care. We emphasize in Chapter 6, where feasible, to please include mothers, other parents, and community representatives in research design and monitoring processes. I'm not going to go into the research matrix here in this presentation, but urge all of you to have a look at Chapter 6 and review the research matrix, as it does lay out quite a number of priorities that were shared from global as well as country level experts and stakeholders. And next slide. So we have heard that this really is a call to action. It's a collective call to action, and we need enormous commitment, political will, the investment of resources and time to really make sure that our small and sick newborns are receiving the care that they need when they need it and where they need it, and that they're in fact able to thrive well into the future. I'd like to now turn the conversation over to Ornella, who will be speaking about the modeling and data collection around newborns and during COVID. Thank you so much.
Thank you, Judith, and thank you to Victoria for this fantastic presentation, which gives us an idea of how it's really possible to accelerate progress on neonatal health and survival, and identifying also the intervention that we could implement at higher coverage and with better quality to ensure that we accelerate the progress and to reach the SDGs. And in the slides that you can see here, on the left side, you can see the blue line, which indicates the type of acceleration in neonatal mortality reduction that we need in order to reach the SDGs. But at the same time, at this moment, we are confronted with the epidemic of COVID. And so the question is, what will be the impact of COVID on this curve, on this progress that we would like to achieve? And also we know that and we heard that improving coverage and quality of care is critical, both for neonatal survival as well as for the thriving of these babies. And we know that by improving these two elements, the coverage and the quality, we can really achieve a better survival and health. But again, what will be the impact of COVID on countries that already have some kind of suboptimal coverage and suboptimal quality of care? So this is a bit the topic of this last presentation, which it looks actually at the current efforts that partners are doing with WHO and others to measure and modeling in order to understand better the impact of COVID-19, both directly and indirectly on neonatal health and also on the health of mothers and children. So what we are doing is collecting country reports, analyze them in order to look at the distribution of the cases and the deaths according to geography, age, etc. For us, it's important, of course, the age in this case. Then rapid surveys are conducted to look at the disruption of services, and then modeling again are using the list tool of which we heard about. The tool can be used to look at the indirect effects of COVID-19 on maternal neonatal services by constructing different scenarios, and I will show some slides about that. And then, of course, we have research studies going on to look at real data on the effects of COVID-19 on pregnancy outcomes, as well as on newborns, and as well as the clinical characterization of the disease in specific age groups, and in order to be better able also to design the management. So this is just from the case reports that we are collecting. This is an example of how data can be showed, but fundamentally I want to show this to indicate, to confirm that in the newborns, the COVID is not affecting much in the newborns, and we have a very small proportion of cases in this age group. Actually, newborns here are combined in the group of 0 to 4 years of age, so it will be even less, of course, so the case proportion in the newborns. And for what concerns deaths as well, we have very few deaths in the neonatal group. This is again, it's 0 to 4 years, but we know from the case reports that very few newborns have been affected by COVID-19. And it seems that, I mean, it's not a virus that affects the pregnancy and neonatal period as much as other viruses like influenza, rubella, or Zika. But at the same time, while the direct effects of COVID-19 seems to be limited when it refers to the newborn or the pregnancy outcomes, what concerns us much more are actually the indirect impact, the indirect effects of COVID-19 on maternal and newborn health services, because the availability, the accessibility, and the quality of health services for both the pregnant women and the neonates are much affected in almost every country across the world by the restrictions or by consideration that people can have, both the mothers, families, as well as care workers. So, and the type of policy that at times are put in place that make access to services less easy. for mothers and newborns. So with this, there's been modeling is very useful in this case because can help us to create scenarios of different level of coverage and estimate the additional mortality that can result from this reduction in coverage or utilization. And this is basically the same exercise that we heard about expanding services for reaching the SDGs, but instead with scenarios where the service instead of being expanded are reduced. So the institute, the Guttmacher Institute, for example, has estimated that on 132 countries, a 10%, just a 10% decline in service coverage of some services, essential pregnancy and newborn care, could result in 28,000 additional maternal deaths and 168,000 additional newborn deaths. And then there is over 1 year. Instead, in a similar study but conducted on 118 low middle income countries, where with different scenarios over 6 months. So for example, the least severe scenario was with coverage reduction between almost 10 and 18%, and wasting in children increased of 10%. With this type of scenario, which was the less severe, the result would have been an increase in 253,000 additional child deaths and more than 12,000 additional maternal deaths. And then, of course, with additional restriction or reduction in access to care, the number of deaths are, of course, becoming much higher. But if you look at the real, pardon, if you look at what are the data, the real data that we collect from the countries, for example, through the WHO survey or from the UNICEF situation tracking, you know, these surveys are done, collect information directly for country. And of course, you don't see the entire world, but still a high number of countries. And this survey that was done, these two surveys that were done in between May and June already indicate a higher reduction in or higher disruption, let's say, in the service, either partial or full disruption. But for example, in antenatal care, more than 50% of countries report disruption of services, and in the deliveries in health facility also decrease of more than 1/3. In 33% of countries report partial or full disruption of facility delivery. And so the problem we can expect then that the number of deaths that derive really from a reduction of access to services will become very important. And so we need the real-time data to understand the situation, to understand COVID better, the disease, but also to understand the impact of the disease on the services themselves. And because at the moment, being the virus relatively new, a lot of public health decision needs to be.
Ornella, you have a lot of background noise at the moment. Sorry.
I don't know what it is.
Okay.
And now?
Yeah, it's better. Thank you.
I don't know what it was. So the line. So what I was saying, yes, a number of public health decisions about implementation of essential services have been based on rapid surveys, estimates, and models. But we need also real-time data to have and quality primary research data on the impact of the disease in order to better understand and better respond. So at the same time, we are confronted also with challenges in terms of weak monitoring system for newborn care in countries. This doesn't make the task of understanding the COVID-19 in this population group very easy. So what is going on also to help us to understand better the disease is actually the research that is coordinated by WHO and done in collaboration with many countries and I think very promising because I'm referring to the research and the core studies on pregnancy, newborn and child outcomes. So this and also nutrition and feeding. And this type of studies are following up cohorts of women, cohorts of children will help us understand better the disease, both direct effects and indirect. So for the direct effects, for example, the effects of COVID-19 infection in pregnant women, specifically on maternal, fetal, and neonatal outcomes, because a lot is not known, and we are debating, for example, on the vertical transmission. By being able to follow up a big number of women across different countries, it will be possible to understand better also this type of outcomes. And also by using the same protocol, of course, of data collection, definitions, and so on. Then the other important aspect we would like to understand is the clinical characterization, because on that we will have to discuss and understand and develop the management in different ages groups, because of course a newborn is very different from an adult. Its immunizations, immune system is different, and this is why the symptomatology of the babies who get COVID, get infected with COVID, it needs to better understand, needs to be better understood. Then we have, and then of course these core studies can be used also to understand what are the effects of the pandemic on the quality and on the coverage of essential health services, and in this way to devise better policies that can ensure still access to services, but with safety. So there are a number of benefits basically from this type of protocols, these solidarity protocols, these studies that are done multi-country. They will allow to harmonize data from these core studies and they will provide an opportunity for having high quality information. But also this information can be used and shared rapidly with the national government and with care providers, and can also provide real-time real data for planning and implementation of maternal and child health services. And then, of course, can also be used to monitor the impact of COVID-19 pandemic specifically on the services for mother and children, including those for small and sick newborns that require are the center of our specific attention. So, and I would like to conclude by reminding that, yes, the impact of COVID on pregnant women and on newborns doesn't seem to be very important directly, but it will be certainly very important indirectly. And in fact, children are not the face of the pandemic, but they risk being among its biggest victims. Thank you. And actually, I would like to acknowledge the authors of Chapter 6 and those who have supported also helped to develop the slides for these presentations. And remind you the next webinar will be not on 29 July because we canceled the 29 July webinar, and it will be instead the next webinar on 12 August, when we will present the introduction to the new standards of care for small and sick newborn. And finally, I also would like to let you know that by the end of August, probably on the 26th, there will be the launching of the new every newborn coverage targets 2020 to 2025. Thank you very much, and I am handing over to Bene for the discussion.
Thank you very much, Ornella. There have been only a few questions so far. Please keep typing if you have more. The first one was from Nina Kada asking if there are a streamlined set of indicators to measure and track the quality of sick and small newborn care in low and middle income countries. And if not, are there any plans to develop them?
I can take this question on the indicator. Yes, the answer is yes. We are, first of all, we have developed, there are a number of indicators that have been developed under the standards that are developed like a menu of indicators that the countries can select by both input, outcome, and output indicators. So there are different type of indicators people can select to assess progress in the implementation of the standards of care for small and sick. And then with the partners, we are also discussing a subset of indicators of quality of care and process indicators that can be used instead at global level. And there will be, we are planning to have a meeting on these topics, indicators, on neonatal health indicators and how to use and the definition by probably in the fall, probably in November. We wanted to do before, but now with COVID, we have postponed. So probably it will be November, and very likely will be online, not the face-to-face meeting.
A question about what you mentioned, the indirect impact on newborn and also on the importance of data. Do we have any disaggregated data on newborn outcomes by adolescent pregnancies that are probably going to go up after COVID?
At the moment, we don't have, but we are collecting them. So because these cohort studies, in fact, will help us to this type of information, because we are really following up a number of pregnant women. So we have very small numbers if they are taken only country by country. But at the moment we pull together the data, we will have also this information. But an analysis done already on the adolescent pregnancy, no, I've not seen it. But it will be done, it will be possible, yes.
Okay, I will continue with the COVID question, the COVID-related question. Do we know anything at this point about the impact of COVID on stillbirths and abortions?
We know only very few. I mean, we know that this virus doesn't seem to be very lethal compared with other viruses during pregnancy. So it doesn't look like that there is a huge amount, huge extra number of stillbirths of negative outcome. However, we are starting to receive reports, but they are very, one report from one country, one case from another country. So very few so far reports that indicate that the placenta can be infected by the virus, and the virus can replicate in the placenta. So in this, while until few months ago we didn't have the virus was not found in the placenta, the amniotic fluid, etc. Now it seems that placenta can be infected by the virus, and so this will, if it is confirmed or true, of course, on a placenta infected that can lead to complication that can go from the stillbirths to the lower rates and this kind of issues. But these are still very few reports. They need to be confirmed, and with many more reports. Personally, I think it's possible. I mean, but it doesn't seem to be a very important outcome compared with what, I mean, we would have seen much more if the infection would have been rubella or, I don't know, Zika, influenza even. So it seems that for some reason that we have not understood yet, there is some protection as well in this during pregnancy compare, yeah.
There is a comment as well, still related to the pandemic, from Nina Gatka, sorry, saying that yes, the pandemic has revealed fragile health system, but it also has shown some innovation that can to make the system more efficient. And if we could capture and disseminate the report of this innovation and how this has been done in the last 4 months, that will really contribute to the overall health system. So maybe we can direct the participants in this webinar to a few reports. Nina, I know there is also several series of webinars specifically on maintaining quality health services for maternal newborn child health during COVID and what this means practically in the country. But I'll let the panelists answer if they can point out to some innovation and reports and the resources for this.
Yes, it's true.
Hello, Benny.
Yes.
Hi, this is Judith. I just wanted to, for just one moment, if I could, I want to go back to the previous question because I think it will then tie into, I want to just add a little bit to what Ornella was talking about, and it might then tie in also to this information about innovative service delivery.
Yeah.
There was back in April, there were a group of researchers, modelers who used, and Victoria, maybe you saw this, they used the Live Save tool to look at the indirect impact of COVID-19 on maternal and newborn health. And they looked in 4 countries, India, Indonesia, Nigeria, and Pakistan. And essentially what they were trying to model is what is the secondary impact of the COVID pandemic on increases in maternal newborn deaths as well as stillbirths. And they essentially, in those countries, were modeling that there's a potential 31% increase or 766,000 additional deaths in moms, newborns, and of course also stillbirths in those 4 countries. And so, and it ties back to, as Nina said in her question about the innovation piece, again, this quality gap, the you know, access to health services, those are being stretched, they're being limited, et cetera. And so I think that's something too that obviously we'll really need to be keeping our eye on as we move forward and look at ways to strengthen health services and make sure that women and newborns are continuing to get basic and essential healthcare services as well as more emergency or intensive care services. But now we're back over to you and other panelists on this question of innovative service delivery.
I see that Gagan wanted to also comment on that point. Gagan?
Right. So just a couple of things. One on Nina's question about the implementation guide. So UNICEF and Government of India worked on an implementation guide, which is something which can be easily adapted to a country level thing. And I can share, Nina, with you that implementation guide. And also currently NEST is working on an implementation guide, which would be an online kind of a guide. The question from Dr. Zulfi on the stillbirths. In terms of the public health impact on stillbirths because of more of the secondary impact because of delays in access to the intrapartum care, I tried looking at the HMIS data from some of the big countries. And what is very interesting is in South Asia, though the skill attendance at birth in India, Pakistan, Bangladesh has gone down tremendously, but the number of home deliveries have not increased and number of stillbirths have not increased. So it seems there are major issues with data capturing within the HMIS. While if you see in the African part, the West Africa and East Africa, the impact is much lesser. It's more on the lower end of the John Hopkins model as compared to South Asia. But these are something of the early kind of, macro level things which I picked up. That's it. Over.
Very much. I have a question here for Judith, about the 5 strategic objectives that you have mentioned, used based on the INAP one, that are very useful to discuss just newborn care, but whether, so the question is about whether within country, this should not be integrated within the broader RMNCA-H framework. And if that's the case, do you think it would be useful to identify the objective based on the various arms components of the health system?
Yes, in fact, I couldn't agree more. And I think there's information throughout this entire document that shows, and certainly with Victoria's explanation of the LiveSave tool and the modeling that she and her team did, that the health of a newborn is inextricably linked to the health of the mother as well as the care that she is receiving. And as we all know, over the life cycle, we can position girls and adolescents and women to have more successful and better outcomes in terms of their pregnancy along that whole life cycle. And that includes family planning. It includes nutrition, etc. So yes, I think it's hugely important that this is seen as a comprehensive package of services, and that women and adolescents are getting the care they need pre-pregnancy all the way through to the postpartum period. And then of course, making sure that we're extending the birth interval from to at least 2 years, so that we're increasing again the outcome and well-being of subsequent pregnancies and the health of newborns. So that's very high level. But again, I think it's really important that we, in our advocacy, in building that enabling environment, in building health systems, again, as we're talking about mothers and newborns and stillbirths as well, that we're looking at that entire life cycle and building the services to ensure that women are getting the care they need when they need it.
Thank you. I see there is now a discussion in the chat about Gagan's comments earlier on. Gagan, do you want to answer?
Yeah, as I said already, that it's more about capturing in the HMIS. And what is more interesting to see is even the private sector deliveries have gone down significantly in one of the countries' HMIS. So yes, definitely the institutional births are going down, but the stillbirths capturing still remains a major issue.
Yeah, it has been always an issue to capture the stillbirths. So I think it's part of what I was saying is a measurement challenge. And I really hope that these cohort studies, both those who are that are looking at the direct effects as those that are looking at the indirect effects, will help us to really picture better also the stillbirths. And the of course of reduction of utilization of services. And even more, it would be interesting to see which kind of different strategy we can use in order to avoid this reduction in utilization of services, because I think that would be, it's really terrible. It will really reverse the gains that we've had over the past years in terms of maternal, neonatal, and child survival and health. And it will take long to go back to where we are and to improve again.
Thank you. I have two more questions. One on KMC, asking if KMC is still effective, and if so, are there any standard quantitative theories and questionnaire available?
What was the second part of the question, Bene?
Are there any standard quantitative theories and questionnaire available related to kangaroo mother care?
But kangaroo mother care in general, or in the context of COVID in general?
I suppose so. Yeah, there is no mention of narrowing it down to the COVID context.
So yeah, kangaroo care is also in the standards that we are, of course, is very much promoted, very much among the intervention that there is new research results coming that to support even more kangaroo mother care earlier than before in the community and so on. So and this is reflected also in the standards that we are going to publish soon with the related indicators.
Yeah, so more on the standards, and that ties in with the next webinar in this series. A question on whether there is an implementation guidance document developed to support countries to operationalize the upcoming standard of care for small and sick newborns.
Not really. We will use the same platform and mechanism that we are using for the other standards. but we have not developed a specific guidance for the small and sick. Yeah, interesting question, but yeah.
Gagan, do you want to add to this if you want to talk about what the NEST team is doing?
UNICEF is working very closely with NEST both on the supply side and the implementation guidance side. So they are coming up with an online implementation guide, but also I can share one of the videos where we have unpacked in 45 minutes the nuts and bolts of implementation of small and sick newborn care. So we can put it with the resource material of this webinar series, which people can access. Yeah.
Excellent. Yes, I will send this
everything.
together. Yeah, I will send this with the presentation and the recording. Thank you. Thank you, Gagan. I don't see any more questions for today's panelists. So if that is the case, I will hand over to Gagan. We'll close this session.
Thanks, Benedict. And just to put the things in the current perspective, all the 5 scenarios that this chapter took into account were of increasing levels of coverage. No one at that time even thought that we might be in a situation soon where we will be facing a scenario of actual decrease in coverage. So some work for all of us. And as we conclude, the message is loud and clear. With the need for investing in care for small and sick newborn increasing by the hour, the funding and resources available are at a risk of decreasing due to COVID response. We need to lend our collective voices to protect, preserve, and track the financial, physical, and human resources needed to deliver the care of small and sick newborn. And with this, we reach the end of this fascinating series. And before I sign out, I would first and foremost like to thank Benedict for steering it so efficiently all along and doing all the heavy lifting behind the scenes, and to bring it so seamless to all of you. Thanks, Benedict. We owe it a big time to you. Thanks as well to my colleague Sheu, Chadbab, the editors of the report, to today's panelists, and to those of you who could join this webinar today. Trust me, you did the right thing in the morning today. And as Ornella said, we will be taking a pause now for a few weeks, and we'll be back with more action in August, and this time with the standards for small and sick newborn and the launch of ENAP targets for the next 5 years. It's a big event. Stay tuned, as they say, for more of the new normal. Thank you so much.
Thank you so much, everybody, and Gagan today. Thank you. Bye.